Okay, it'll be 5:30 there now. Perfect. As usual, there may be a couple of people wandering in over the next few minutes, but we'll get started now. So again, this is our monthly pain rounds, and it's sponsored by a variety of sources. So I should tell you that because then we can pay your travel and stuff.
Wow.
But so it's sponsored by a variety of sources that allow us to have speakers come in, and we're a little opportunistic about how we do that. Sometimes there's strategy and sometimes there's opportunism. So today is the latter. Terry Borsuk he's actually currently engaged in research and advisory work with the John Howard Society, right?
Yes.
But he is a graduate of University of Toronto PhD program, and you can see from the title that his interest over time has been in stress and stress responses and pain care.
Yes.
And so I forget exactly how it came about, but Terry and I ended up corresponding a while back about the opportunities for research collaborations and so on that might be occurring here at McMaster or at the Michael G. DeGroote Institute for Pain Research and Care. And I said, well, maybe the easiest thing to do, first of all, would be come over and give rounds, let people hear what you're doing, we can hear what you're doing, and then we can work from there and talk about what opportunities might exist. So that's how we got to today. And then I had an opportunity to meet Terry at the Canadian Pain Society meeting earlier and chat about this a bit more. And when he forwarded his material and his slides and so on, personally, I found this an intriguing topic and an exciting piece of work. So having said that, I will not delay you any further. Terry, thanks for making the trip over today and
my pleasure.
Presenting, and look forward to your talk.
Thank you. Thanks so much, Norm, and thank you very much for having me here. Really, really appreciate it. I'm very excited about this. I'm excited about being here. So I have three objectives that I want to talk about today. One is I want to convey a little bit about the contribution that the endogenous pain regulation system, this built-in system that we have to regulate pain, and the contribution that that makes to pain treatment efficacy. I want to review a little bit of some research showing a link between stress exposure and this EPRS, endogenous pain regulation system impairment. And then I would like to explore some of the clinical implications of these research findings. So when a clinician gives a patient an analgesic drug, not just an analgesic drug, but really any kind of pain treatment, the drug or the treatment is not the only thing that the patient gets. There's also the expectation of some benefit and pain relief. There's the hope that maybe with this medicine or with this treatment I'm going to feel better, a little bit of a sense of control, or potentially there's some previous experience with this treatment. All of those things that can have an impact on the treatment, on the pain treatment. And so the psychological, I'm a little bit far from the, I guess I have to point like this. Okay, there we go. I have a temptation to go over there. So all of these components together induce an expectation or provocation of some relief. That provokes the EPRS, this endogenous pain system that we have, to actually produce some pain release through opioids. Usually these are opioidergic systems. Oops. Uh-oh. We have a frozen. Yeah.
Try it.
Enter. It's frozen. Uh-oh.
Any good ideas?
Oh.
Wow.
Oh, that was weird. Okay.
I think if you click on the cursor, it may lock it on your phone. But if you
Oh,
just use
I
the
see.
cursor as a slider.
Okay, that may be.
Yeah.
Okay. So the overall effect, the overall efficacy, the overall effect of any kind of a pain treatment is a result of two components. If it's a drug, there's the pharmacodynamic component. It's the activity of the drug, the specific activity of the drug on the nervous system. And then there's the endogenous pain regulation system component. Those two components are involved in producing the overall treatment effect. Now, there is a very interesting paradigm that's been used to isolate these two components. Because if you give somebody a drug and you measure their pain relief, you don't know what component is producing how much of an effect. So with this open hidden paradigm, we're able to actually isolate those two different effects. So using this paradigm, a drug is given to a patient, or given to a particular patient, but is given in two different ways. In the open application of the drug, the patient is given the drug is given the drug in full knowledge that they're given the drug. So you have a physician who is saying, well, I'm going to give you this drug, it's going to reduce your pain, and so the patient has the expectation of relief. In the hidden application version, the patient is also given the drug, is given the same dose, but is done so in a hidden fashion, so that the patient receives the drug without his or her knowledge that they're receiving the drug. Using this paradigm, we're able to isolate how much of the effect, the total effect, is due to this endogenous component. So we have here the results of one particular study, and this paradigm has been used in a number of different studies to isolate this component. So you can see in the case of metamizole, you can see after about 1 hour, the patient is reporting some reduction in pain. You can see here, this is the open injection. So the open injection is they get the drug and they get the expectation. But you'll notice here that in the case of the hidden injection, the patient is also given the drug, but without the expectation and gets no benefit. So the entire benefit of that drug, in this case, for these patients, is due to the expectation or psychosocial elements that induced this EPRS activity. That is what it seems to be producing these effects. But they're not the same for all drugs. So buprenorphine, you can see that after about 1 hour, the pain does seem to show a reduction, but it's more so and it's earlier for the hidden. In the case of the open injection. So this does seem to be a more effective drug. It seems to actually have an effect apart from the endogenous component. But the open administration, which is how the drugs are usually given, we see a much sooner effect. Now, this is a particularly interesting study I found because it not only replicated those findings, but also provided an additional wrinkle. So in this case, we see here that this was given to healthy participants who were given a heat pain stimulation to their forearm. And they used a within subject design, which means that every subject got all three of these conditions. So they were given the drug with no expectation in a hidden fashion. They were given the drug in an open fashion with an expectation of analgesic effect, or they were given the drug with an expectation of drug interruption. They were told that the drug is now going to be stopped. So you can see here that at baseline, their pain rating on a 0 to 100 scale was about 65. And when they were given the drug in a hidden fashion, it dropped to about 55. So it was a reduction of about 10. This is remifentanil. But when they were given the drug within an open fashion, they were told, you're receiving the drug now, their pain ratings went down to 45. So another 15-point drop, which is quite significant. But what's particularly interesting, I think, here is that the negative expectancy actually wiped out the benefit of the drug. So in the no expectancy, see the level here of no expectancy and the level of negative expectancy, these here are actually, there's a difference, so that this shows that these are different. So in other words, what happened is that when when the participants were told that the drug would be interrupted, their pain level went right back up to what it was at baseline, completely eliminating the beneficial effect of the drug. So the EPRS can have very powerful effects. It can be responsible for a big proportion of the total overall effectiveness of a drug or a treatment, and it can wipe out the benefit, any of the benefit produced by the drug. There was also another wrinkle to this that was done in another study that found that the EPRS component was responsible for more variability in pain treatment efficacy. So that when patients were given the drug in a hidden fashion, the variability, this is coefficient variability, this is just a measure of variability, this cross-patient variability, the variability went down. That's because it doesn't have the EPRS component. When it was administered in an open fashion, it has the EPRS component and has a lot more variability. So both psychological blockade and pharmacological blockade, they used naloxone actually in this particular study to see what would happen if they blocked the effects of the opioids. And they found that it was basically these results were produced by opioidergic pathways, and that when they were blocked either through psychological means or through a drug, it reduced the effectiveness of the drug and reduced increased the variability. So, in sum, if you have 4 different patients who are given a drug, they will respond. Their pain levels will decrease to different degrees, and a lot of the variability in that outcome is due to EPRS differences across patients. As a matter of fact, more of the variability across patients is due to these endogenous factors than could be ascribed just to differences in response to the drug itself. Okay, so the EPRS is a very critical component. It has important clinical implications because its function contributes substantially to the overall efficacy of treatments. So what would happen if this EPRS was in some way damaged or made dysfunctional? So I found that there wasn't very much in the way of human studies on this, but there were a number of animal studies that found that in fact when animals have been stressed, either in early life or more contemporaneous paradigms, these studies observed heightened sensitivity to pain, hyperalgesia, diminished opioid analgesic responsiveness. So they were given morphine and they didn't respond to the morphine as compared to the rats that were not stressed, who did respond to morphine. And they found lower opioid receptor density in several of the structures that have been shown to be involved in the EPRS pathways. So there seems to be some very specific changes that are occurring in these EPRS pathways that are producing these clinically important results, at least in animals. And this is just a description of one of the studies. So the stress in this case was immobilization stress for a period of 8 weeks. They showed greater sensitivity, and they showed that the morphine, the administration of morphine was less powerful, was less effective. So my research comes in where my research comes in is I wanted to know, would these results apply to humans? Would they generalize to humans? So the first question that I had to get at was, well, how do you measure the EPRS system? We can't, take participants to our study and then open up their brains. And so we had to use a little bit of a different approach. So there are different phenomena that have been shown to be mediated by this EPRS system. One of them is placebo analgesia. We know there's been a number of studies that have shown that at least expectation-based placebo analgesia responses can be attributed to these EPRS pathways. There's also stress-induced analgesia. So when organisms are stressed, when they're threatened, stressed, we also expect to see some sort of an analgesic effect. And there's also conditioned pain modulation, CPM, which is where you apply one form of pain, like let's say you have somebody immerse their hands in like ice cold water, so they have that kind of a pain, and then you test their pain response someplace else, let's say on their arm, and so you would expect to see that the amount of reduction in pain in the arm as a result of having their arms immersed or their hands immersed is an indication of this conditioned pain modulation effect, and that's also been shown to be mediated by this in EPRS. So my studies, the two studies I'm going to be describing today, use the first two, placebo analgesia and SIA, as measures. So the first study, the placebo study design, I asked participants to complete questionnaires that assessed their stress. I used their life stress exposure. I used two different types of stress measures. One was more of an objective measure of stress, which asked them to report on their exposure to stressful life events, things like a loss of a job, a loss of a loved one, divorce, things like that. That's the SSS, the Student Stress Scale. That was just, the Student Stress Scale is simply a version of a life event stress scale that's very often used in stress research, but for students. It had life events of applicability to students. And the other one was a past year serious life event scale, which asked people if they had been exposed to any kind of a serious life event, and there was a definition of a serious life event. And then the perceived stress scale. So the first two were objective measures, just your exposure to stress, and the third one, the perceived stress scale, has to do with the degree to which you believe that you can manage the challenges that are presented to you in life. So it's kind of like your perception of how well you're able to cope with things. Oh, I'm sorry. So after they did that, they came into the lab, and I gave them a pre-treatment pain test, a baseline pain test to see how sensitive they were, and I'll explain how that worked. And then they were randomly assigned to either placebo group or control group, which I'll explain in just a sec. And then they were given a post-treatment effect. So that's the overall design. So how did the pain test look like? So the pain test used an algometer, pressure algometer. Participants put their fingers down on this platform here, and then the algometer was lowered at a constant rate onto the back of their finger, and we have 3 different fingers. And then they were given a button to hold. And at the point in time at which they began to feel the pressure as painful, they pushed the button, and it registered the pressure. That was the threshold. And at the point, and the pressure continued. And at the point in time that they felt that they could no longer take any additional pain pressure, they pushed it again and said stop, and that recorded the tolerance. So there were 2 pain measures for each. Okay, and then after this pain measure, after they were given the pain measure, the difference between the groups is in the placebo group. So they were given an envelope with a message, and they were shown that they were going to have some cream applied to their finger. And inside the envelope was a message. In the case of the placebo group, the message was, this cream contains a powerful painkiller which has been found to substantially reduce pain sensitivity in most people. And in the control group, the participants were told that it was simply a moisturizer that was needed because they were being exposed to repeated pain trials. Otherwise, everything was the same, and we used the envelope to maintain a double blind, or a single blind actually. So the experimenter didn't know which group the participants were assigned. Okay, so what did we find? We found, in fact, that when I put all of those 3 pain measures in a regression, I found that they together accounted for about 30% of the placebo effect. So, which in the placebo effect in this case was defined as the difference in pain from the pre-treatment to the post-treatment. So, it was that change. That was the placebo effect. And so it would accounted for 30% of the variance. That's quite a bit of the variance. So, and then what we found when we looked at the individual measures is that both the SLE, the stressful life event and the student stress scale, both of these are the objective measures. We saw exactly the effects that we were expecting. They were hypothesized. So the people with high levels of stress, as measured in both of these ways, showed diminished placebo responses when compared to the people who had lower levels of stress. So it seemed that stress exposure, at least according to those two measures, was predictive of a diminished or in some way impaired placebo response. There was no statistically significant difference between the groups in the PSS in this particular study. So we'll see in the next study that there is a difference, and there's kind of an interesting effect going on there. But at least in this study, that's what it was. And the effect size was pretty large. I mean, explaining 30% of the variance in these kinds of studies is actually quite a bit. If you think about all the different ways that the pain can vary across people, and to say a 30% is pretty substantial effect size. Okay, so the stress-induced analgesia. So as I explained, this basically comes from the fight-or-flight response. When you expose somebody to some sort of intense threat, the body goes into the fight-or-flight response, and one of the components of the fight-or-flight response is an analgesic effect. And that effect has been shown to be mediated primarily by opioidergic EPRS pathways. So once again, it seems to be a reasonable way to index or quantify EPRS activity or responses. This study required that we stress people, so we used something called the Trier Social Stress Task, which has been shown to be a very effective way of experimentally stressing people. And what it does, I think I have a slide. Oh, yes. So what this does is, so there's two components. One is you ask people to present a 5-minute presentation. I think it is like why they're the ideal candidate for a particular job, and they have to convince a couple. There's like two people sitting. Very evaluative, very judgmental people who are sitting in front of them, and they're looking very serious, and they have these clipboards, and they're kind of shaking their head, making the participants feel like they're being very nervous. And then if that doesn't make them nervous, the second component is asking them to count backwards, starting at 1022 in steps of 13. If they make a mistake, they got to start again. So if one doesn't do it, the other one does. And it was interesting to look at the data. It is the case that sometimes the presentation, some people liked the presentation, it didn't make them nervous at all. But when they got to the math, they got nervous, or the other way around. They got very nervous about the presentation, but not about the math. So this has been shown together to be very effective at producing stress. Okay, so I used exactly the same questionnaires. Prior to the lab session, used a very similar experimental design to kind of a pre-post experimental design, randomly assigning people to these two groups. So the stress-induced analgesia group got that TSST manipulation as I described. The control group was given. I wanted to mimic the actual motions and the talking and everything that was involved in the TSST, but without the social evaluative component, which has been shown to be the active ingredient that gets people very anxious. So they were asked to do some preparation, and then they were asked to present something of personal interest, like the movie that they had just been to, for example. And they were just to deliver it in front of a computer. So there was nobody there. There was nobody evaluating them. They just had to stand up and talk about something. So they had some of the same cognitive. I wanted to control for things like distraction, for physical movement, all those kinds of things, as much as possible to really make sure that there was this difference between the groups. All right. So what did I find here? I found that for the SLE, so these are the same measures, SLE and the SSS. Now, the SLE was not statistically significant, although it was very close. It was marginally significant, and the SSS once again had the same effect as the placebo study. So, in other words, people who had reported high levels of stress exposure prior to the study showed diminished SIA, stress-induced analgesic effects, compared to their counterparts who had been exposed or reported less stress prior to the study. a similar overall effect with SLE, although it didn't quite make statistical significance. I suspect that that was because of the numbers of participants, and it may have been slightly underpowered. Maybe with some more participants, there would have been an effect. But what's interesting here, I thought, was that in this case, the PSS went the other way. So it was actually low PSS. So people who were low in perceived stress, or they reported low levels of perceived stress, who had a diminished SIA effect. So, and so I was trying to figure out why that would be. So it appears, so I did some analyses, and I found that there was in fact a pretty strong correlation between, it was about moderate, about 0.4 to 0.5 correlation, which is a pretty strong, pretty good correlation between the PSS scores and some subjective ratings of their amount of stress. So after I subjected the participants to the stress induction protocol, they were asked at various points to rate their level of stress, their subjective level of stress. I found that there was a moderate correlation between their stress response or subjective stress response as they were going through it and the PSS. It's possible, I thought it's possible that potentially the people who rate themselves as high on PSS are just maybe more responsive to the stress. In other words, they were reacting to the stress the way they should be reacting to the stress, and therefore showing the SIA effect. Whereas people who were showing very low levels of perceived stress may have been just not as reactive to the stress induction method. So that's one possibility. So it's an interesting effect. I'm not, and that's speculation. We need to collect some more data to really find that out. But that's an interesting distinction between those two. So there's an objective and subjective. I have another suspicion that the PSS is measuring something other than stress. I think it's measuring things like confidence in oneself, or self-efficacy, health, self-efficacy, and things like that. So not specifically stress. One of the things I would like to do is what we call a moderator analysis to see to what degree potentially PSS or other measures, potentially resilience, like social support, or things like catastrophizing, potentially might act as moderators to this effect. So in other words, people who may have greater resilience may not show this effect. So even given a certain level of stress, people who have strong resilience factors or characteristics may be in some way buffered against the deleterious impact of the stress experiences. So I didn't have enough power to actually perform those analyses in this particular research, but I would like to collect some more data and test some of these hypotheses. So I think I can say that with these two studies, I've shown that compared to their less chronically stressed counterparts, participants reporting high stress levels of stress exposure exhibit both diminished placebo and stress-induced analgesic responses, both of which do suggest some impairment. So the implications, implications for clinical practice is what we see here is that stress. So I think probably you're all clinicians involved in seeing patients, most of you are, and I'm sure you appreciate that stress can definitely have an impact on your patient outcomes, on the etiology of pain, on the development of quantification of pain, a lot of different factors. People who are in pain, people who are very stressed, maybe more tight the muscles, muscular effects and stuff. So stress can have this effect. But what I've shown in this research, the pathway by which stress can have this impact. And it appears that it's doing its evil deeds, at least partially through impairment of this EPRS system, this endogenous pain regulation system. So also, if you can see that the overall, as I mentioned at the beginning, the overall effect of pain treatment is due to the specific effects of the treatment itself and the active components and the EPRS. So to the extent that the EPRS is in some way impaired or damaged or whatever, we might expect a less effective pain treatment. And it also suggests that this would also potentially explain a lot of the cross-patient variability. So different patients respond differently. It may in fact be because there's different levels of stress. Different levels of stress have impacted the EPRS in different ways. So this research has shown that yes, stress can absolutely have an effect on pain. It's shown that one pathway or one mechanism by which it can have this effect, and I think is kind of moved I think stress into a position of concern from a clinical perspective. That if patients are stressed, there really might very well be an impact to their to potentially the development of pain conditions and to the response to treatments. So this is really only the beginning. I have many ideas, and I think there's still a lot more needs to be done. So one of the things I'd like to do is to delve more into different measures of stress. For example, people who that SSS measure, that just simply asks to check off on a checklist what the stresses you've been exposed to over a period of time. But people may very well ruminate about stresses. So it's not just the stress event itself, but they may think about maybe a conversation that they had, issues at work or whatever, and the toll that the stress is taking on them may not be the events themselves, but all the rumination about the past, worry about the future, and it may be that those are the more insidious forms of stress, the more potentially damaging forms of stress. So I would like to delve more into the measures of stress to get a little bit more specific. Also, this research has been conducted with healthy university students. I would like to further this research in a clinical population. In fact, I'm working collaborating with a researcher right now to do this, investigating a post-surgical sample to see if these results hold in a post-surgical sample. And the other question is, if stress is impairing EPRS function, then can it be reversed? Is there something that can be done potentially to reverse this? Let's say somebody comes in, you see that they're very stressed. This may impact their treatment efficacy. I wonder if potentially going for CBT or some sort of stress management program may in fact help to, over time at least, repair some of this damage. So that's it. Thank you very much for attending. Do you have?
Thank you. Yeah. Well, excellent. I'm going to start by asking Dr. Hapidou if you have any questions.
In fact, I met Terry at CPS and we had a conversation.
Yes, we did.
By the poster. So, very interesting research that you're presenting. Takes me back to my co-professor experiment for my PhD research.
Yeah.
We've been well aware of the effects of placebo, resolution and analgesia, and nocebo, and you're kind of also alluding to nocebo.
Yes, sure, nocebo.
The negative expectation, and so and now you're delving more into stress measures, and you're talking about going from a healthy university student sample to clinical samples and people perhaps who have had maybe chronic exposure to stress. I would think that the system would break down a lot more, in those cases.
For sure.
And then I'm also wondering about the effects of personality, such as, for example, state versus trait anxiety, and all these kinds of things. So, and I know you said you're delving a lot more into it. So it's thoughts that I'm having more than questions right now.
Yeah, no, I really appreciate that. Yes, I would absolutely. This was really kind of this research was a little bit of a proof of concept, just to see if there was some effect. But I think that I would definitely like to add a lot more measures to really kind of determine what characteristics may be, contributing the most to these effects. Maybe in certain types of people that, these were average effects. Maybe with certain types of people you have even stronger effects. So it's great, I think, from a clinical perspective, to be able to predict who's likely to show these strongest effects.
Yeah.
So, for sure.
And one more comment that I
Yeah,
had,
yeah.
when you talked about the 30% of the variance
Yes.
in the results were accounted by the stress measures.
Yes.
30% of the placebo response. And then I'm thinking that the placebo response, when you leave it alone in just about everything, is 30%.
Yes.
Right? So I found it interesting that you had the 30% of the measures account for 30% of the placebo
Yes,
effect. That is
interesting,
30% of the whole effect.
Seems to be a magical number there.
Yeah.
Yes, that is interesting.
Yeah.
Yes.
Thank you so much for the presentation. Great topic to talk. And my question is, in your researches, do you see this? Is it your vision to come up with a questionnaire or with a tool that we can screen the patients beforehand? So while we are formulating a plan for their pain management, if we know already they do have this impaired system, we work more on CBT and stress management?
Yes, I am. I am actually doing that right now. Yes. So I'm looking, because they're really, getting involved in this research actually was a little bit frustrating to find really good stress measures. There really aren't a lot of good stress measures. So, of developing one.
Thank you.
Thank you.
Any
other questions?
There's actually the two folks online. If either of you have questions, I think the process is to type into the chat line there, and Indu will let us know what your question is. I had a couple of, well, we're seeing if they have any questions. So one thing, for example, is when you talk about stressful life events, it does make one think about the whole concept of adverse childhood events, which is known to be a predictor, or is starting to be associated as a predictor of either things like addiction risk or chronic pain states in later life. And that's an interesting mechanism that might be part of the process. We actually have one of our researchers here, Jason Bussa, who's has a clinical trial underway looking at offering CBT for patients who are identified as they have a SPOC quiz, so a somatic preoccupation scale, which they use for patients who've had traumatic lower leg fractures. And so in patients who score high on that test, suggesting that they are likely to have long-term pain, they're being allocated into a CBT group. So it may get at a little bit of that question. So that would actually be a good conversation for you to have with someone. I can connect you with Jason if you haven't already spoken with him on.
Yeah, we met actually at the
Okay. So one of the other things is, how do these relate to, say, other physiologic measures of stress, like cortisol levels or heart rate variability or things like that? Have you done any of that sort of correlated work?
No, that's another piece that should be done, absolutely. Particularly with heart rate variability is something that I have done in a different context, which has been shown to be a good physiological indicator of stress. So no, I haven't done that, but absolutely that would be very, very helpful.
We have a pediatric research group here, perioperative pediatric group, who started out looking primarily at anxiety, perioperative anxiety in kids, and are now expanding to look at the relationship between perioperative anxiety and pain, persistent pain after surgery. But they're using sort of salivary cortisols and EEG monitoring and heart rate variability monitoring. So again, another interesting.
As measures of anxiety, or?
Yeah, well, so they're using the cortisols, for example, and the heart rate analyses to link up with these standardized questionnaire tools for the anxiety measures, and they do state and trait, as Dr. Hamilton was talking about. But so again, neat stuff. So that project is beginning, but
okay,
interesting.
That would be, yes.
Yeah.
I would
So
love
that's
to know,
Cheryl-
would love to know
Cheryl
more.
Chow and
Yeah.
Bush.
Mhm.
Yeah.
Okay.
Dr.
Oh, yes.
We also spoke at your poster at CPS. I'm just wondering, you know, so you talked about stress and placebo and have not touched on the CPM, but I'm wondering if you have the intention of looking at comparing the different mechanisms, and if something, you know, there might be value in looking at, you know, is there a more optimal way of assessing
Yes.
the EPRS, and which
Yeah.
one might that be?
Yes, well, that's a good question. I've seen that over the last few years there has been a fair bit of use of the conditioned pain modulation method, CPM method, to assess EPRS function, descending pain regulation function. So yeah, I think it definitely would be useful to have some sort of way to compare those, to see which is a better measure. Yeah, no, for sure. Yeah.
Other questions?
Any other questions?
Some suggestions.
Sure.
Yeah.
So the pain, I think it's a good idea to have a standard pain measurement, but pressure, right? So
Yes.
so there are different type of pain modalities, right?
Yes.
So that one you may have to explore.
Yes.
And
Yes.
once that's validated, then you can subject some type of group patient with anxiety and depression.
Right.
Go through that,
Right.
test and see what happens.
Right. So you have different methods of inducing the pain. Yeah. And I think it's going to be interesting. So there's that, and I think it's going to be interesting to see how the post-surgical pain comes out. It's more of a natural pain, to see whether they come out differently. Different effects. There may very well be different processes that are involved. Also, I would like to do some sort of study in the chronic pain. The problem is with chronic pain, and maybe you guys have an idea, I'd certainly be very I'd love to know more. But one of the problems with doing research on a chronic pain population is the pain itself is a source of stress. You know, so how do you tease those apart is an interesting question. So if you have any ideas, because that's a tough one. It's a tough nut to crack.
Plus, people are on different medications.
Yeah.
A ton of medications, both for the pain relievers as well as antidepressants and, tranquilizers and, all sorts of things.
But you see, you'd have to have some way, you don't know what comes first, unless you do some sort of a longitudinal study. You don't know which comes first, because the pain produces the stress exacerbates the pain, and So it's how do you, So
So the post-surgical model is actually a good one to use for that.
Right.
Because
And that's why.
Most of the time, we start out with no pain or relatively little pain until you cause it.
Until you
and then
cause
a
it.
certain proportion of patients go on to have persistent post-surgical pain.
Right.
Most, roughly 75–80% recover, even if you treat their pain appallingly, but there's sort of 20–25% that go on, depending on the surgery and other factors, to have persistent pain.
Right.
So that's where your predictive piece becomes more helpful. That's the model that we use conceptually. That's how we focused our research in the institute here, is to focus on that persistent post-surgical pain as a conceptual model for dealing with chronic pain.
Right.
So who are you working with for the post-surgical pain piece?
It's Joel Katz.
Okay, the king of post-surgical.
Yeah.
Good start.
Very, very lucky to be here all the time.
That's a really good group to work with, and they have their transitional pain program, of course, offers a behavioral intervention in patients who are requiring lots of analgesia post-surgery.
Right.
So that's another piece of that model.
There has been research looking at the predictive power of measures like of EPRS measures and post-surgical pain quantification and persistence of pain, and it's been somewhat mixed in terms of the findings. I wonder to what degree maybe maybe potentially stress may produce an effect, an EPRS effect that's distinct from other forms of dysfunction, EPRS dysfunction. So maybe if we measure stress, potentially in addition to the EPRS function, it may be more predictive of post-surgical. So it may actually be able to explain better or predict more accurately who is going to be more likely to have some sort of a quantification of pain.
Yeah, one of the problems is trying to identify remediable stress model, right? You know, like which pieces of it. So that's where you're talking about, can you intervene at some point to change the stress?
Right, exactly.
A lot of chronic pain care, you know, the non-pharmacologic, non-interventional components of chronic pain care involve largely behavioral or, you know, sort of mindfulness, CBT kind of interventions to try to return a sense of control, or to develop a better awareness of, you know, the variability and try to minimize the sort of stress or worry components of pain, much as you're describing there. So
who knows? It's possible that maybe some of the benefits of like CBT that has been shown for pain may in fact be mediated by this EPRS system.
Well, that's what you want.
Yeah.
I was just wondering, thinking almost in reverse, has measures of resilience been sort of compared against that?
Right.
The stress response.
Yes. No, not looking specifically in this. Yes, but totally. That's like next.
There's never a shortage of things to do.
Yes. There are. Yeah, there's no shortage.
There are good resilience measures. Because you're right, that's a really interesting thing. Let's look for a group we can actually make.
There
are. Yeah.
So you did that type of measure in your study for?
I'm sorry. Would you ask?
Resilience measure you did for this type of?
Oh, the PSS, the perceived stress scale.
Yeah.
I'm thinking that's more of a picking up some sort of resilience or ability to sense that you're able to control.
Yeah, so then you look to your data by splitting both the high and low level, and then the variance.
Yeah, the only thing is I don't think I have enough power to be able to do that kind of analysis, unfortunately.
You started with 80 subjects and then 50 went through the.
Yes, the reason is because not all the people who completed the questionnaires came to the lab.
The students.
That's right. That's right.
Actually, it's an interesting question. Did you, and again, it's a small numbers thing, but did you look at the difference, or is there a difference between perceived stress and more objectively measured stress? So do you get people who reported no stressful events, but were walking through life saying, holy Jesus, my life is so stressful, and other people whose mother died during their divorce as their house fell apart and they went bankrupt, and they're saying, it's okay.
Yeah, it's okay. All's good. Actually, what's interesting is I did look at that correlation between those two, and it was very small, like 1.2. Very small. Yeah. I was surprised. Yeah. So they really,
there's divergence between measured and perceived stress.
But I even wonder whether it's a divergence between like measured and perceived stress. I think it may even be that what they're calling the perceived stress scale may even be getting at something else other than just like perception of stress. It may be just.
So when you say there's no you mean there's no correlation between the objectively measured stress and perceived stress?
Right.
Which basically makes the point, right?
Yeah.
They're not related.
They're not related.
So the perceived stress sounds like it's measuring something very different than
very different.
More objectively.
Yeah, that's where personality comes in, right? Because people want to present themselves in different ways.
Yes.
Like you said, I can handle this, that's
That's right.
They bottle things up, you know, they. But I remember one of the first things that I learned in school, when I was in graduate school, is that there is very little correlation between behavioral measures and physiological measures. Sure. You know, on the same kind of component that you were talking about. So I'm not surprised the physiological measure and the behavioral measure has very little.
Just a couple comments going back to the surgical thing, just for your information. I work with knee arthritis primarily, and there's been several studies looking at CPM pre-post knee replacement, And at first, the literature was looking kind of mixed, but it's looking a little bit more so now like it does indeed get reversed.
Oh.
So, and they're just thinking, you know, you're taking that horrible joint out and putting, you know, a new one in. And so we probably need to see a few more studies that way, but it's kind of going more in that direction. At first, it was kind of one or the other. And the other thing I wanted to say is that I'm currently doing some phenotyping research, a bunch of different pain variables, and then looking at predictors of phenotypic membership. And right now, it's kind of our early results, but both optimism and chronic pain self-efficacy are protective indicators of being in kind of the most sensitized group.
Oh, I see. Optimism. Yeah, so it's coming back to this, it's the sense of self-efficacy control.
Yeah, the positive
The
psychological
positive.
aspect, yeah.
Sari, thanks very much for coming over.
Thank you.
This was
Thank
really
you.
interesting.
My pleasure.
Yeah, very good. Thanks, everybody. So a reminder, I was talking to Joe earlier, and I was sort of pondering on the fact that I have not